Okay. Hi all. Today I'm going to present regarding one case that I experienced last week. This is a respiratory case. First of all, I would like to present about the medical history. Doctor, can you hear me?
You can tilt
Then
the phone slightly towards you so that the video is better seen. We are only seeing the top part of your face.
okay. Family history. Mother is 30 years old, G2P1 with previous history with previous SVD, presented with symptoms of gastroenteritis and threatened preterm labor. She received 2 doses of steroids and 4 doses of penicillin G before delivery. AR done 3 hours before delivery, and it was clear. Clear. Medical history: 35 plus 1 weeks, born by urgent C-section due to fetal deceleration. Cried soon after birth, but needed a deep suction twice because of excessive secretion. Then baby maintained SpO2 more than 92%, but at 8 minutes of life, he had mild respiratory distress with grunting, nasal flaring, and subcostal retraction. So PEEP 5 and FO2 30 was applied for 10 minutes, then shifted to NICU. Apgar 8 and 9 at 1 and 5 minutes of life. Respiratory wise, in NICU, so once we got the message that baby will be transferred to NICU, the our NICU setup was ready to deliver the baby. Baby was initially put on CPAP in the ventilator itself, CPAP mode, with the FAO2 25%, PEEP 6 started. It was started on first day itself, and later on, after the blood gas, it was slightly acidotic. pH is 7.273, PCO2 58, PO2 37.8, lactate 1.7, and bicarb 23.8, base X is minus 0.2. Then doctor decided to put the baby on bubble CPAP instead of ventilator CPAP. The PEEP 6, FAO2 21, and flow 6 liters started. Then gradually baby got improved. You can see the second blood gas also in that pH 7.364, PCO2 43.5, PO2 42, lactate 1.8, bicarb 23.5, and base X is 0.6. Then baby moved to high flow nasal cannula, flow 3 liters, FAO2 21, started on the third day. Then gradually baby was maintained. um, the workload of breathing was improved, and baby put on room air. Then
Dr.
after that,
Prithviraj, please mute
no,
yourself.
okay. Then
Dr. Prithviraj, please mute yourself. Jyoti, can you mute Dr. Prithviraj, please?
Then also lab investigation initially done was CBC, then CRP. CRP was normal. CBC also in that HB 14.1, WBC count 11.9. Because of this clinical condition with the respiratory distress and baby's presentation, doctor decided to start IV antibiotics. So the blood culture also sent blood culture report no growth after 48 hours. Can you move to the other
Yes,
slide,
move to the
ma'am?
next screen. Yes, Jyoti, please move to the second. We have the second slide. Continue.
Okay. And actually, I didn't mention here regarding the cardiac wise babies having vital signs normal, and also the this baby's active, alert, everything. And GI wise, peroral baby kept NP on first day, then peroral feed started second day via OGT, 8 French inserted. Then the position. Then initially started with 5 second abdomen.
Meera, sorry to interrupt. Please stop your video,
Was
please.
soft and
Meera, please
then
stop your video.
intake output good also.
Can you hear? Meera,
Huh?
please stop your video.
Yeah, okay, doctor. Yeah.
Your signal is weak. Continue.
Okay. Then intake and output intake was 149 ml per kg per day. Output was 5.6 ml per kg per hour, and also baby pass stool and positive 42 balance. And lines only peripheral IV inserted. 10% dextrose started 13.9 ml per hour. Likewise, before I said ampicillin and gentamicin started that 146 mg 8 hourly. And gentamicin also 10 mg OD started. Then after that, once baby is on room air, then baby was fine for discharge at the time of discharge. Can you share the next slide?
Have the first X-ray.
This was the first X-ray. After this X-ray, doctor decided to put the baby on bubble CPAP.
Okay, just
Then
wait 1 second. Let one of our team comment. Dr. Sai, do you want to comment on this? Or anyone can unmute and try to interpret the X-ray? Who wants to interpret the X-ray? Yes, Dr. Ajeshwar, please.
Was around 8 to 9 spaces. At this point, the child was on, the baby was on CPAP.
She was just going to start.
And so this X-ray showed a slight ground glass appearance, and but the lungs were well aerated with the good amount of spaces.
Okay. So what would be your impression, and what would you do next?
The next is if the baby is not maintaining, and if there are retractions or any downscore or worsening, and FiO2 requirement is increasing, so I would like to start on CPAP.
What would be your differential diagnosis here?
Differential could be, sir, it could be TTNB.
Yeah. So TTN could be a diagnosis. Mild RDS is also possible.
Yes, sir, mild RDS.
And we can't differentiate congenital pneumonia, so we have to go by the history and risk factors. Yes. Continue, Meera. Thank you, Dr. Ajeshwar. So, Meera, you can tell about the second X-ray. When was it done?
Okay, doctor. Then after putting baby on bubble CPAP from the ventilator CPAP, doctor did second day the next is chest X-ray. In that there are some finding outs in the right side of the. Could you some of the doctors can explain because I cannot read the X-ray.
Okay. So, Rajeshwar, do you want to comment again?
So this X-ray again shows well aerated lungs, rather around 8 to 9 spaces of aerated of lungs, and right side of sir, I don't know whether it's a collapse or something, but it is a cardiac shadow, I think.
Anyone else wants to comment?
Yes, sir. Good evening, sir. Dr. Parneet.
Yeah, Dr. Parneet,
this was right. Yeah, sir. Good evening, sir. Sir, I think this is a right upper lobe collapse. Although the X-ray is central, I mean, there is no shifting and all that, and heart shadow is also appears to be normal. This upper zone, there is a right upper zone collapse. And
I mean, even though you said it's well positioned, it's slightly rotated. If you see the spine, and also the clavicle position is different.
Yes, right.
So that mediastinal overlap on the right side, and we also see the mediastinal flat lining, which is often mistaken for a mild air leak. You see the rim of the right heart border, you will see the lucency, which is actually the mediastinal fat lining. It's commonly seen, and many times we get confused if it's a pneumothorax, especially if there is a rotation, as in this case. Meera, was there any clinical impact, or after the X-ray, no change was done?
After the second X-ray, doctor said to put the baby on right side up position. And
they thought of a small pneumothorax possibly. Okay.
Yeah, then baby was having mild tachypnea while handling, but doctor didn't do any intervention. After high flow, continued antibiotic, then the baby was okay on room air, then baby got discharged.
So most likely this is not a pneumothorax, it's only the mediastinal fat line. Okay, continue. Next slide, please, Jyoti. Okay, Meera, we are on this slide 6.
Okay, doctor. But slide I cannot see here.
It's okay. The one starting the first point on patient safety.
Okay.
You have your presentation with you?
Yeah. Patient. Nursing considerations for patient safety. We can confirm the first of all, we should confirm the CPAP device is correctly set up and is functional on the desired pressure, gas flow, and oxygen settings. Ensure gas is warmed and humidified. Then all infants receiving assisted ventilations are to have a TP's resuscitation device. So we will make sure before the admission of the baby to a unit, to the bed assigned for the baby, we should make sure that CPAP is get ready, and also the TP's resuscitation device should be set. PEEP and oxygen flow and this air and oxygen blender, everything should be kept ready before the admission. Can you please move to the next slide, ma'am?
Done. Continue. Jyoti, whenever you move the slide, you confirm your mode. Okay, so she can't see the screen.
Okay. Then ensure adequate humidification will be achieved. Check the adequate water level, commence gas flow through the device, and turn on the humidifier. So we should make sure the humidifier turned on, because the humidified oxygen should receive. Otherwise, it will dry the airway. The humidification will helps to moisten the secretion, and also it prevents infection. Then measure once baby will be admitted to the unit. For the CPAP, we should measure the head circumference so that we can select the appropriate size of the cap. So we should check the head circumference to check the size. Provide a snug fit. The cap should be snug fit to the head of the baby. That is above the brow level. Below the neck, it should fit snugly, and also covering both ears. It is important to fit the head correctly. Otherwise, the prong will not position properly. If either we can use prong or the nasal mask for the CPAP device. Hello, ma'am. Could you please move to the next slide?
She has moved. Here, continue.
Yeah. Observe the effect of CPAP, and we can also first once baby is connected to the nasal CPAP or with the nasal prongs. So we should observe for the change of the heart rate, any oxygen saturation, respiratory rate, the work of breathing, also often oxygen concentrations can be reduced. So once baby is connected to the CPAP, once the baby's condition got improved, we can reduce the oxygen concentration FiO2 as per the doctor's order, and also we can get a capillary ABG. Also, we can assess the baby's response to the nasal CPAP.
Next slide. Moved already.
Inform medical staff or traditional nurse practitioner if the infant has increasing oxygen requirements despite of effective CPAP. So even the baby's on CPAP, we nurses who is handling the baby should assess the baby that 4-hourly vitals. It should reflect in the monitor, and also we should check for the work of breathing. If the baby's work of breathing is increasing, we need to inform the transitional nurse practitioner or the physician. Then nasal CPAP device should be connected to the blended gas supply and oxygen concentration titrated with the infant's SpO2. So SpO2 level, we have the monitor, and we have the alarm limits also, set alarm limits. So we can also adjust the titrated SpO2 level with the oxygen concentration.
We are already on the next slide.
And the cap size, we can choose appropriate hat size. There will be different one from 22 to 25, like 25 to 29, 29 to 36, or more than 37 for large babies, in order to provide a snug fit and minimize movement of the prongs. Connect the correct size Fishran Packel nasal extension tubing. The tubing that is connected, usually we are using the Fishran Packel material. There will be two sizes, at 50 mm for premature infants and 70 mm for larger infants. Then only it will connect correctly to fit the nasal mask to deliver the correct pressure. Choose a Okay. Target pressures are reached. Next slide. Target pressures are reached when the water bubbles. If there is intermittent or regular loss of pressure, you may need to reposition the infant, insert a dummy, or use a chin strap to achieve an optimal seal. So we should see how the CPAP is working effectively. Means there should be continuous bubbling. So if there is no continuous bubbling, we should check for the positioning of the infant. We can either reposition the infant or adjust the mask for proper sealing, or even though sometimes we can use a chin strap to achieve an optimal seal. Next one is observation and documentation. As nurses, we should observe the baby for any deterioration or any improvement in the condition of the baby, and also observe the machine, CPAP machine, check the water level, the temperature, and the pressures we are adjusting, the size of the nasal prongs, mask in use, ambient and circuit oxygen levels, and isolate temperature. The core temperature should be maintained. So isolate temperature we should adjust according to the gestational age and weight of the baby. Equipment safety checks such as suction, resuscitation devices, and also ventilator. The intravenous syringe pump if the baby is receiving any IV fluids, IV or UVC. Then pumps and monitor. Alarm limits should also be documented during our care with the babies. Continue to maintain optimal humidity for the inspired gases. Ensure gases are delivered at core temperature. This already I mentioned before. Then next is the suctioning. Suctioning actually it is not routine and is performed on a needed basis only. The nurse should always optimize the work of breathing, humidification, infant position, the thermal environment, and the enteral feeding techniques. If suction is required, the color, consistency, and quantity of secretion should be noted to the physician. Position and handling. The infant should be positioned to facilitate comfort and optimize respiratory effort, prevent posture and movement problems, and encourage midline orientation of the hand to face. Usually, baby on CPAP, we will put on prone, supine, and sideline position. The only thing we need to prevent posture and movement problems, so that it will optimize the respiratory effort, and also gentle release of the nasal mask during intervals to prevent pressure injury. Likewise, whenever during the care of the babies, we should gently release the mask to avoid the pressure over the okay, pressure on the nose, and also the periorbital edema. We can reduce the periorbital edema. So we need to gently release the nasal mask.
Continue. We are on the next slide.
Parental involvement. Even the babies on CPAP, we will promote the kangaroo mother care. So frequent skin-to-skin contact should be encouraged. So it will improve the neurodevelopmental and hemodynamic status of the baby. Infants on CPAP must have also everyone knows that this one, but this is much more important, like 6 French gastric tube to prevent the gastric distension, prevention of complications like we should prevent the complication while the baby on CPAP or baby is receiving oxygen, such as retinopathy of prematurity, pneumothorax, also gastric distension.
Well done. Very nice presentation, and thank you for taking the effort. I know you had a very busy night shift, and my little friend is near you as well. So nice to hear
Yes,
the voice.
okay, thank you.
So
Okay.
best wishes to your family as well. There are a couple of questions. One is on chin strap use. So
Yeah.
Jyoti, you can stop sharing the presentation. So you can keep your video on if the signal is okay now, Meera. Try turning on your video again. So the question on chin strap, what would be your response? I mean, which babies do you use chin strap, and how do you use the chin strap? What do you use for it?
Chin strap, any with facial abnormality?
Okay. What do you use for a chin strap?
In our unit, we are not frequently using, doctor, but with a dragger, with a dragger, there is usually
Okay,
we are.
Yeah. If you want to attend to him for a second, I'll answer another question. You come back. It's okay. So Dr. Palnivel, I think you asked about pneumothorax management.
Okay.
No, you can attend to your child and come back. No problem. Take your time. So the pneumothorax management approach has changed a lot. Most of you might agree in your practice as well. You might have seen this. And we do have a talk by Dr. Vineet Bhandari on pneumothorax management. And if Dr. Karthik is able to arrange something during the contact session, I think he's already planning to have an arrangement to show these management issues as well. So we will discuss humidification, chest drain and things like that in the personal contact as well. But in terms of approach, I mean, when I was training like 25, 30 years ago, we were very scared of pneumothorax, and what he mentioned about going for invasive ventilation if you have a pneumothorax was kind of suggested. And we were very worried about extubating the baby when they have a pneumothorax till the chest drain was removed. So the concept has changed, and for the past 15 years, and there are also recent studies which were published on management of pneumothorax. So needle drainage is adequate in most of the pneumothorax if they cause symptoms. If they don't cause symptoms, like in this baby was on bubble CPAP and they continued it with just positioning, that may be adequate. Even the needle drainage is only needed if the ventilation is compromised. You can continue non-invasive ventilation, but be careful not to overuse the pressures. Try to use as minimal as possible to maintain the baby. And if needle drainage doesn't help and if baby is worsening, especially you would have a lower threshold to ventilate. I mean, obviously, you don't need to ventilate just because there is a pneumothorax, but if the baby is not coping, you would ventilate them with a lower threshold. You may need to do pain relief and do the chest drain in those cases. So the number of babies who receive chest drain has dropped a lot. And regarding the chest drains, most of us may consider using the pigtail catheter if you have the option. It's a little cumbersome when you initially do it, but once you get experienced, it's easy enough. It's gentler and stays in the chest better. The trocar assist method is quicker, but you have to be careful, especially for using on the left side, because it goes quite close to the heart. Any comments from anyone on the pneumothorax management? Okay. So, Meera, if you're free, just continue your response, please.
And doctor, with the obstructive sleep apneic babies, we can use the chin wrap, the chin strap. Usually we have in our unit, so we will put that one to close the area, including the chin, especially for baby with obstructive sleep apnea.
Thank you for that. I mean, we also don't routinely use chin strap. It's a bit cumbersome, and the setup you described, I mean, thankfully we need less and less of that as we are weaning babies to high flow fairly quickly, and more of us are using bubble CPAP, or I mean the ventilator CPAP or NIPPV with the RAM cannula, for example. So it works as a nasal interface. We don't have these hats, the pressure on the nose resulting from that as well. Do you have any tips for reducing nasal injury? You already mentioned some of them during your presentation. So do you want to just summarize the tips to reduce, because that's one of the most common problems with the non-invasive ventilation? Do you want to comment on nasal injury prevention?
Yes, doctor. Usually during the care of the babies with a nasal mask or prongs, we will release that one during the care every 2 hours to release the pressure, and we will massage the nasal bridge to avoid the periorbital edema. And also we can alternate with the nasal mask and prongs. And also, if nasal prongs are using, don't use any lubricants, but slightly saline can instill to the area. And also, we are using the deoderm as a barrier to protect the area while we are using prongs or mask.
So do you rotate the prong and mask on your unit?
Yeah, 4 hourly, we used to do that one.
Okay. That's a helpful practice as well. So the pressure points are different. You're getting a break from the exposure to the same pressure points. And again, if your baby tolerates high flow for a period of time, you can alternate high flow and CPAP as well. I mean, if you don't have an NIPPV. So these are techniques you can use, but the humidification, the attention to detail to switch on the humidifier first, not to expose the baby to any period without the humidified gas is very important. The nasal saline installation is okay. I suggest suction once at least to make sure the nose is patent using the smallest catheter possible. So once per shift, gentle suction, and don't hurt the septum, just go straight to the side. And don't use high pressures as far as possible, just to make sure, because Non-invasive ventilation efficacy depends on the nose being patent. So if nose is blocked and you keep suctioning to unblock it, you create more inflammation. So gentle suction to maintain it patent will help to avoid. These are in the
Okay.
extremely small babies, it's more important. Thank you very much for
Okay.
a very nice presentation. Any
Thank-
comments from anyone? We will have 5 minutes for comments and then we'll have a few MCQs. Anyone wants to ask any question or comments?
No, Sridhar, I just wanted to appreciate Meera. Really, she's one of our very young nurses who's the only nurse trainee in this program. Thank you so much, Meera. I really appreciate your efforts. Thank you.
Thank you, Doctor.
Anyone has any comments? Otherwise, I'll start sharing the screen.